In healthcare, we are all a small piece of the 1,000-piece jigsaw. Historically, there's been a perception that the healthcare professional is the most valuable piece, the expert in the room. Yet, with an increasing evidence base on the value of equal partnership, viewing the jigsaw as a whole has never been more important. I'm Juanita Guidera from the HSE's National Quality and Patient Safety Directorate, and in this episode of Walk and Talk Improvement, I'm delighted to welcome Mary Vasseghi and Christine Fenton, who share their experience of patient partnership, and through their stories, we explore how you can continue to develop your engagement skills and view the jigsaw as a whole. In part one of this episode, Bearing Witness Through Life and Death, we spoke with Professor Linda Mulligan and Mary Cregan about patient partnership in the review of the HSE's National Clinical Guidelines for Post Mortem Examination Services. Mary was also a member of that group as a patient partner. She has been a patient advocate for 15 years, triggered by the deaths of her mother to medical error and her 18-year-old son Darius to sudden cardiac death. She is also a founding member of Patients for Patient Safety Ireland. We began our conversation by speaking about her son Darius, who died in May 2005, and how this led to her becoming involved as a patient partner. Mary, can you tell us what happened?
He dropped dead on the bathroom floor. He was an international fencer. He was actually Irish fencing champion. And his heart had never been checked. And what we didn't know at the time is that we have an inherited cardiac arrhythmia, which had already killed people probably in previous generations. So unfortunately, he dropped dead in the bathroom floor, and it was his twin sister who found him. And I wasn't there. Very rare that I wasn't there, but I wasn't there. So yeah, it was a very big tragedy indeed. Yeah. I remember the day that Darius died and I left the hospital, and I had nothing in my hands. I can still see a picture of me walking on the street, and somebody had said that there was going to be a post-mortem. That's why they were rushing me out of the hospital so that they could get ahead and do it. And I remember thinking, what do I do? Where do I go? What's going to happen next? And I just felt completely lost. I needed a hand of some kind to hold, to walk me through. As it happened, later that afternoon, my brother-in-law, who had tried to resuscitate my son, actually gave me a little red booklet from the coroners, but with very little information that was appropriate for my needs at the time. After that first initial, just having nothing and not knowing where to turn, when I did discover a little more, I used to wake up in the morning and think there are other mothers like this around the country, and everybody's very isolated in this journey. Therefore, for me, the initial step was to do something to join the patients or their families together, which was the beginning of a support group. But after that, it was to join. I discovered that I probably knew certain things that the clinicians didn't know about. At the time, they thought this was rare. So for me, it was then to help them learn and us all work together, because we all had the same goal: to stop this from happening and to prevent it from happening. And a patient partnership for me started very early on with Professor Joe Galvin, who's in the Mater, who was the first cardiologist I saw. I marched my other kids up to the hospital and said, I want them seen, screened, etc., etc. And I remember his face. And all of these years later, we've become close, working together with the common goal. And that's what partnership means to me. I was able to speak openly and share things with him, the cardiologist with the patients, and then we set the same goals and agenda to achieve better outcomes for the patients and for the clinicians to make their work easier as well. So for me, that's the partnership. It's we bring them information. They need that information. They have skills we don't have. We have experience that they don't have. And it's bringing it together to improve everything. And that has happened in the cardiac area very much. it was another wonderful man called Dr. Moore, who was the head of the Irish Heart Foundation at the time. He said, right, let's work together. And that was it. Let's work together. And we went down steps into a room, and he recognized that there was no patient involvement in a government task force report that had been done. And he then saw that there was information we as the patients and families had that they didn't have. And his first thing was that we would work together, and we developed a leaflet. That was it.
Okay. And was that your first experience of patient partnership?
Yes. Yeah. I hadn't had any experience like that before. And it was completely new to me. And it took time to build up the trust, I think, on both sides. I think everything, you can understand a clinician is going to look at a bereaved, grieving parent, and then I suppose the parent has to manage that grief to be able to work in an objective manner. That wasn't easy, and it can't have been easy for them either to be trying to work with somebody who had a little bit of medical knowledge, because I had trained as a nurse many years before. So I knew a little bit of something. So it was on both sides. I think for any clinician working with a patient, it takes work and understanding at a deeper level, and at a personality level, at a behavior level, at an opening, listening level of respect. There's a lot involved, and that's what true partnership means then, because you build that relationship on respect and trust, and it's up to both parties to do that. And I really don't know that partnership can work without it. That would be my feeling.
Okay. And if I was to say to you, because I know the immediate question that comes to my mind, and I'm sure probably somebody listening, would be, how do you create that trust?
For me, initially, it was, I knew that clinicians and anybody involved in healthcare have gone into healthcare to help people. And therefore, their knowledge and my knowledge may not have been the same thing. So it was getting that knowledge to the same point and building trust and respect and being respectful. And it's a difficult thing to explain, but I suppose it comes from trust and respect. And building the trust comes from the respect and the sharing of knowledge and listening. Listening is a huge part, for them to listen to us and for patients to listen to the clinicians, because things that patients might see as being obvious or needing to be done, the clinician will have a lot more knowledge from the medical point of view and know that certain things can't be done. So both sides, and I don't like to put it as sides, but there is always that slight line in the middle, because we're both coming with different packages, and it's joining those packages together. Yeah.
Yes. Yeah. I'm very conscious as well that you have a huge breadth of knowledge, and I know that you're studying for your PhD in a different topic at the moment. Would you tell us a little bit about that?
So my daughter has a rare disease called tuberous sclerosis complex, and I'm allowed to speak about it. She's given me permission. She's 31, and this rare disease is genetic, and it causes tumors to grow. Tumors can grow all over your body, every organ. And depending on where the tumors grow, people will be affected differently. Some people may not know they have the disease. Others will be so profoundly affected that they're in institutions and not able to speak or look after themselves. There are high level of epilepsy, and there are many other complications. So here in Ireland, we had very little research. About 1 in 6,000 people are affected, but we actually don't know who they are, where they are, what treatment they're receiving. And there are international guidelines, and it's very important that those guidelines be followed. And we actually don't have the very basic information. So I'm recently retired, and I was giving out that nobody had done the research. And one of the professors, Professor Colin Doherty, who's head of the School of Medicine now in Trinity, said, "Okay, Mary, well, do it yourself." And I said, "Well, I'll do it myself." And he said he would supervise me in doing it. But it's important to collect the data. So we've done an audit in the hospitals to see if the guidelines are being adhered to. Just within neurological services, I've interviewed patients and I'm interviewing clinicians to see what it is that needs to be done. In other countries, they have centres of excellence, how that should happen here, what type of a network should happen, how do the clinicians want to look after the patients, what do the patients want. So again, it's trying to get both sides of the story. And that's why I'm doing this, because it's very important the patients get the care. But then again, where do the clinicians get their expertise from? And they need to be supported. There are a growing number of us who are on that line trying to help change things for the better for patients, using our experience and knowledge and working very closely in partnership then with the clinicians, because that body of data is powerful, I think, to bring it from both sides together.
I really think that's phenomenal. Do you think it will make a difference? Do you think it's making a difference at the moment, having that insight and that knowledge that you can bring to the table?
I think definitely yes, because my experience all of these years, as I said, is that these clinicians that I've met them at the bedside with my daughter very ill, in rooms where we're talking of strategy, or in rooms where we're talking what can happen or what is the solution or what maybe resources are needed. I think it makes a big difference to be working closely together.
Do you think every patient needs to be able to bring that level of knowledge to the table?
I think every patient can bring their lived experience, and I do not think that people know the power of that lived experience themselves. I didn't know the power that my daughter's lived experience would even have on me. She had recently qualified. We had been to an appointment, a renal appointment. It was good. Her results were good. She's now on the proper treatment. And I saw her eyes filling up. And I said, "What's the matter?" And she said, "Oh, Mum, I've just realized I'm only going to have 5 days annual leave." I said, "Why?" She said, "Because I have to have all of my other appointments." She has to see 11 specialists every year. And I have to keep 5 days for Christmas. And she had just qualified. This was her first job. She'd only been in her job for about 2 weeks. So that particular experience affected me in a way to move me. So when you go into a clinician and you're sitting there and he becomes extremely aware of what that lived experience is for you, I think patients need to share that a lot more.
If you're thinking about advice that you'd give to staff who are involving patients in this type of work, what would your top suggestions be for them?
I think the patients will need to be supported to become involved. Also, perhaps the stage of the illness or perhaps the grief that they are at is going to matter. I think you have to listen, and it's not easy to listen because you may be hearing things that you don't want to hear or that you don't agree with. I think it's important as well to help somebody who wants to become involved and to keep it measured, not to rush, because there's a time for reflection that could be needed. Sometimes patients think, "Oh, I'm going to be able to do this," and then they get burnt out quite quickly. It does take a type of measured approach, yet an open approach.
If there was somebody thinking of becoming a patient partner, what advice would you give them?
I would say, yes, if this is what you feel that you want to do, whether your motivation, whatever your motivation would be to ask your healthcare professional how you can help, and then ask what organization you can join. There's Patients for Patient Safety, there's the Patient Forum, perhaps there's some type of a group within the hospital you're attending. Perhaps if you have diabetes, there is a diabetic association or arthritis association. These groups are already formed and they have people like you who are affected by something, and wanting to be part of the organization. Sometimes people join organizations just because they need the support and the information, but within those organizations, you have people who are trying to improve services and work with the clinicians and with the other healthcare professionals. So that would be the first thing to do, would be to join something that already exists, because in there you'll find the information and the strength to support you.
Has the work and your involvement in it brought you joy?
Do you know, joy, I never thought of the word joy. I suppose I like to see that when I look at the cardiac side, whatever little bit for me is that if somebody has survived where they might have died, or looking at the improvements that can be made along the way. And, you know, when I look at one of the doctors I know quite well, he's just so happy that somebody did something. It makes his life easier. And when I look on the other side at I'm not even thinking of my daughter here, I'm thinking of somebody else, and just how happy they are, that's enough for me. And so I don't know about joy as such. Yes, I suppose it gives me, life is short, life is precious. And I like to enjoy many things. Whether I enjoy that, it must give me something I've never really thought. Shouldn't be answering this like this either. I suppose it must, because I only do things that I like doing. I like doing this because I know it can make a difference. And I enjoy seeing others benefiting from something that I've managed to influence. It's the easiest way of explaining that, perhaps.
Well, I know from my perspective, seeing the impact of patient involvement in this particular piece of work around the postmortems, it was really enlightening, because I think just by virtue of the fact that they were there, they added something to it, and they added a dignity to the work. And for me, I think that was really, really powerful, and a real privilege actually to see that in operation and to see that happening. I just want to thank you for your time today and for your commitment to this, because I do know that you're involved in multiple groups. You talked about burnout, and I can't really, I suppose, since I've had a few conversations with patient partners in recent times, the amount of effort and time and work and commitment is mind-blowing. So thank you.
And thank you. I suppose the bottom line is we're all in this together, the healthcare professionals and the patients, and just there are all thousands of ways of working together, and we can do it.
Thank you so much, Mary.
Not at all. Thank you.
Next, we interviewed Christine Fenton, who made history recently as the first patient partner to interview a CEO of the Health Service Executive at the inaugural HSE Patient and Public Partnership Conference. Christine is a patient and service user and a patient partner who's reliant on HSE services in order to live in her own home. So thank you very much for joining us, Christine. And we might begin with just asking, how did you get involved with the HSE?
I live with a chronic illness, and life was getting more and more difficult. 2006 to 2010, I had my first hospital admission and ended up being in acute services 3 months a year from about 2011 to 2016, and then reliant on services to live at home. I'm a very independent individual, but that reliance was really a lesson to be learned. And part of the journey was learning that I didn't know what was supposed to be happening. I didn't know the standards. I couldn't find the standards. And it was culturally different to my background in education in the UK, where we worked in partnership with relationship. And I really experienced a being done to kind of culture, which was so upsetting and so disorienting. And really, I just did not understand. So I then set out to work out what should be happening. And to do that, I started reading policy. Then I started making connections with people. And it was, okay, how can I change this? How can I be part of change?
How did you make that transition from somebody that was reading policy to actually influencing it? How did that come about?
In part, there was an independent investigation and I was heard. And the hearing and the mode of hearing and the support to enable me to be heard gave me back so much of what I'd lost. And also the new staff that I then engaged with, who were very much of what I believe should be happening, which is that we're two people in a room together and this is what we're trying to sort out. These are the limitations from either side. How do we solve this problem? And suddenly it was reorientating into a world I understood.
You talked about that sort of conversation, an honest conversation. How important do you think that is in order to build that relationship?
Oh, beyond important. It's that valuing of the human being. It's that valuing of my experience to say this matters, which actually means that I matter.
And can you remember the first time you became involved as a patient partner with a formal recognised role with the HSE?
It was to do with the implementation of person-centeredness. Okay. And I'd seen the outline for it, and I had no idea what to do. So I did kind of an application for it. You know, this is what I believe in, this is what I should do. And I was invited to be part of it. So it was attending meetings in Dublin and very welcoming, the people there. And again, the listening aspect of it and the valuing of my voice. But also it was a learning opportunity for me. So it was, again, it was that element of people in the room, each willing to hear each other and each learning from each other. And from the back of that, I was then invited to be part of the Learning Leadership Academy, steering and then involvement with the Leadership Academy. And I remembered that first meeting. I had no idea what I was going into. And my view was, I saw the list of names, you know, all these, you know, high-ranking individuals, if I put it that way, from all over the place. HSE, outside the HSE, and thinking, okay, I go along here and I sit and listen and keep quiet. It lasted for about 10 minutes. Because suddenly I felt at home. I was so welcomed, so supported. But it was very much like I found my home. And I think that's one of the important pieces to me, is that people join things that matter to them. For any partner, it's finding your natural home. What is it that is your passion, that is your buzz, that is your drive, and finding partnership areas where you can follow that route.
Do you think, you know, there are situations where you go as a patient partner and it's not always a positive experience?
Yes, there have been some that I've been involved in whereby it's almost tokenistic type piece. That document, Patient Partnership Strategy 2019 to 23, and they speak about equal voice, equality, partnership. And it has Einstein's diagram, which has a list of from tokenistic through to engagement. And some of the engagements I've had have been, we welcome you along to have your voice. We will let you speak, but we are now going to carry on and do what we were going to do anyway. But we've ticked that box. Or you have the come along, we'll listen to your voice. Thank you very much. That was really important. We'd already thought of it. We were going to do it anyway. But thank you very much. And then you have that piece where you're actually truly involved, where you actually have influence, where your voice is heard, where you see those aha moments where I hadn't thought of that.
Yes.
And I have those aha moments. And it's those two coming together that influence and just nudge and say, okay, we actually need to change direction here, or we need to include this. That's really important. And that's where true partnership is.
Yeah. Do you think it's easy, you know, if you have a negative experience, to keep coming back? Can it be off-putting as a patient partner?
I think it can. And I think there are two facets of it. You can either strive to say this is not patient partnership, which then sets up quite a negative vibe, because you're then in a position where you're saying this is not okay. And if you have somebody who is not willing to listen anyway, it's not okay because they're not listening or not able to hear, maybe.
Yes.
Then you set up a dynamic which actually undermines the partnership you're trying to create, or you say, okay, this isn't for me. This is not worth it. I've got enough going on in my life, and I'm going to take my energy elsewhere, because partnership is voluntary.
Yes. Yeah.
So I think you run the risk of both of those. And I think part of the considerations have to be to create a set of standards for what partnership is. And it isn't about tick box, have we checked your meal? Have we done your travel? And so on and so forth. It's about what support does the individual need before they come to the meeting? Is there any pre-reading? Is it reading, or do we need to have a chat with a person? What supports do they actually want and need? So the two aspects to it. And also some meetings, and it depends what the meetings are and how close to your personal experience and possibly pain that they are, because a lot of people are there talking about their own experiences, that maybe there needs to be some sort of buddy system whereby somebody can go to somebody and say, and again, it's that piece about confidentiality as well, but actually say, look,
Yes.
I was in a meeting today and I really struggled with the content. So somewhere within setting up partnership, there has to be that support structure created. And it may involve people within the group, or it may be that you have buddies amongst other patient partners, confidentiality in mind.
Yes.
Or do we need to think of other options as well, where confidentiality is assured? Some form of, not counselling per se, but some sort of supportive mechanism that is the HSE can provide for certain situations.
Yes. Yeah. There's a lot in that. It's something that strikes me all the time is you go to a meeting, but if a patient partner is coming to a meeting, often their experience of getting there is very, very different. So I know when you go to a meeting, there's a lot of work that goes into making sure that you can be there. And would you be happy to share a little bit about what that looks like?
It is an epic journey, to say
Yeah.
the least. So I use a mobility scooter. I'm reliant on PA support, and so I don't leave the house without PA support. And it is literally a matter of the car has to be loaded, things have to be organised in advance. So the scooter's charged, what are we taking? And I think this year I've been out 12 times in all. So it's kind of, what is the routine? Where are things now? Where do they live? Bringing my own water with me, having food with me, because I may need a snack in order just to keep going, sort of thing. And then where do we park? Because it's a long vehicle. Car parks, are they the right height? So, you're traveling around Dublin. Can you get in a parking space where you can get the back down and get the scooter out? Absolute basic logistics that really can become quite challenging.
And in particular, I'm sure it adds time to a long day if you're going and you're traveling, to get there early to make sure that you have adequate parking and that you can travel from A to B. It's something that we don't always necessarily think about. I know it's not something I would have always thought about prior to having a few conversations with people that are coming from a patient partnership perspective. It's certainly something I hadn't really appreciated, that commitment and that time, because as you said, people are volunteering to do it. One of the things that I wonder about is, when you're coming to a day like that, what motivates a patient to come and to give that time?
I think it comes from that piece, and I always go back to the Ombudsman report 2015 and 2018, learning to get better. And it is that piece about when something's happened to you, you don't want it to happen to somebody else. And I think it's that drives people, that they've seen something in the system that they've experienced that wasn't optimum, whether it caused harm or disturbance or whatever it was in their life, or something that is absent. And it's highlighting that. And certainly everybody that I meet who are patient partners, there is a drive, there is a passion there. And I think it's the passion is the driving quality.
Yeah. And there has to be a lot of grace there as well, because it takes a lot to come back into a system where you haven't had a positive experience and try to change it. It's not something that everybody can do.
It does. I think one of the pieces about coming back after a negative experience is what you meet when you first enter a room, or the precursor to entering is actually what tells you whether this is going to be an okay experience or not. And it's a gut response. It isn't a thought response. It's this is going to be hard, or this may be challenging, or this may be uncomfortable, but it's okay to do.
Okay.
And that will come from first interactions with people.
Yeah.
That whether it's a phone call or a meeting, online introduction, that really needs to be thought through about the manner. And a lot of those that I've been involved with, that has been such a constructive process, some less so.
Okay. Speaking of the less so, how do you think power and politics can impact that experience of patient partnership?
Hugely.
Yeah.
We still have quite a lot of power within the HSE. And because it's an organisation, and it's an organisation based in law, it has power.
Mm.
And a single patient or service user voice trying to get heard is a challenge in itself. And it is very easy for any member of staff to say, I am not going to hear you.
Okay.
They may say, I will listen to you, but I am not going to hear you.
Yes.
And therefore, the power lies with the HSE. My view is we need to transition to our HSE, whereby it is equal power. Every voice counts. It's about human interaction. It's about person-to-person interaction. And we all have bad days. We all get it wrong. We are human beings, very fallible. And it's about having a good enough relationship whereby you can speak to somebody and you just think, okay, there's something not right today. This person is not as they have been before.
Yes.
And the baby could have been up all night, or flat tire on the way into work, or whatever it was. And the person just doesn't have the leeway. And that can apply to anybody involved in the relationship. And it's understanding each other well enough that you can say, okay, we won't bother mentioning that today because
Okay.
the other individual doesn't have the capacity to deal with it.
Yeah.
But to have that nuanced understanding, you need to have a relationship. So how do you develop that relationship?
Yeah.
And going straight into a meeting without having the chance to, hello, who am I? Whatever. And almost defining what an individual's needs are. So there's the National Guidelines on Accessible Health and Social Care. So it's
Yes.
focused on disability. But if you think about that as a format and actually look at what my needs are as a person, and what do I need from other people in terms of support? So am I somebody who prefers to have things written down? Do I need a hard copy of something? Because everybody now wants to use screen, and some of us, and I'm certainly one of them, yes, I can use a screen, but I actually need hard copy because of the way the glitches in my brain prevent me using screens and short-term memory and things. So what are those needs? If I'm attending a meeting in person, what are my physical needs in terms of length of time, that sort of thing? So online, there's been a development of how do we manage online meetings, which has been a learning curve.
Yes.
We need a similar learning curve, how to support patients and service users when engaging.
Yeah.
But that needs conversation about what is it that's actually needed? What are the questions to ask? And what are the open questions to ask? Not what do you need to eat? What's this? What's that? but to actually encourage a conversation so that the person feels safe enough to speak.
Yeah.
And you start developing the relationship at that point, because you're saying to the person, your voice matters. We want to hear you. And how can we make this the most comfortable experience for you?
Yes, yeah. It's quite powerful. I know in our early conversations, you talked about that sort of sense that we're all human, whether you're working in the system or you're accessing it as a patient or you're a service user, that you're human in that space. And that really resonates, I think, because you come to work, you try to do your best, but you could have an off day, and vice versa. It could be the same for a patient, but that trust, something about how do you develop that trust for people? How do you start that conversation at the very beginning? So I think that's really useful. What are your needs? But equally
Yes,
at the same time too, not so prescriptive that somebody feels I have to share my life, personal.
absolutely.
Yeah,
Yes.
yeah.
Yeah. The amount of effort some people make to support partnership is immense. It's almost like giving blood in some respects, but the fact people do it willingly and with passion because as staff they support partnership, I mean, that is just so valuable. And I could name names. I won't. They know who they are.
Yes.
But it is so special. And it's how do we do a blood transfusion into other people to
Okay.
share that around.
Yes, yeah, yeah, yeah. To spread it. It strikes me in some ways that some parts of the system are really evolved and they have patient partnership and they do it so well, and other areas are still at those sort of formative, what does it look like? And there is the big thing that keeps coming in my mind is that conversation about trust. And you touched on something at the very start when you talked about those early conversations that you had with the service providers around the boundaries about what could be done, and being really clear about what was in scope or outside of scope. How do you think that helps or supports partnership?
Again, I think it depends how it's done, because sometimes it can be we're putting the limiters on from the start,
Okay. Yeah.
which immediately closes things down. It's that piece about arriving into a group once the terms of reference have been written. It's too late,
Yes, too late. Okay.
because I'm here and I have no influence on that. Whereas if you're brought in order for something to be started, often there has had to be a process. But there is a draft terms of reference whereby this is what has brought these people into the room. And now your voice is needed to say who else needs to be here,
Okay, to refine it more.
to refine.
Okay.
But also explaining to people that we've had to do this in order to even be able to issue the invitation to you.
If I was to say to you, if you were thinking of staff and patient partners, people that are thinking maybe of getting involved in this work on either side of the table or at a round table, preferably, what advice would you be giving people?
Be open, be yourself, be natural, and truly work to hear. That really matters, because that's often where the nuggets are, to sit back and listen to the dynamics in the room.
Yes.
I think is one of the key bits. I suppose it's learning how to hear and learning where the messages are, and not necessarily coming in with a solution or a what about, but rather raising a question and saying, what I've just heard is this. That makes me wonder, and then have a conversation about the question.
Okay.
Coming with a solution, it closes it down, because everybody focuses on that detail. Whereas if you ask a question, then you open it up and you're valuing the voices. Now,
Yeah.
again, you're doing that within an hour's meeting, 2 hours meeting, whatever it is. So you have to be aware of the dynamics.
Yeah.
So, going back to the question, the piece about quality hearing, which is different to listening,
Yes. Yeah.
and hearing voices and hearing the messages that are not necessarily being vocalized. What is the body language? What are the nuances of facial expressions? Is there a frown? Is there a smile? And pick up on it and acknowledge it, because that's part of what partnership is about. It's part of human relationship. In terms of staff going into it, it is a commitment, but all change comes from doing one small thing.
Yeah.
So start with one small thing. You may not have the energy or capacity within a current work life to take on a big project with patients or service users. But you may decide, okay, over the next week, I'm going to grab 2 minutes with 3 different people and just ask them, what's your experience been today? Would you mind just giving me 2 minutes and tell me, talk to me? One small thing.
And, I really like that concept of doing it at your capacity at the moment. And there is a certain amount about creating capacity as well. I think sometimes there's a perception that if you're going to do true patient partnership, it's going to take much longer. But actually, while it can be challenging to get there and can seem like a slow process, you really get something much more meaningful, and it's infinitely shorter in the longer term because you've really thought through the challenges and the issues that are going to come up. And it's not maybe always going to be perfect, but I do think that it can be shorter, and people's perceptions of time can be a little bit skewed, I think, sometimes on it. The first time that we met, one of the things that really struck me was your capacity to absorb information. I don't think I've ever met anyone quite like you. How do you think that's helped you in your role as a patient partner?
It is hugely helpful. It's partly about seeing patterns. It's about connecting dots. If you think of a forest, and a forest has paths within it, and it has patches of grass, and it has rabbit holes. And I like to get into a helicopter and get above the forest and be able to see the whole forest and gradually fill in the detail of the forest. And I have a picture, and that enables me to connect dots. So every interaction I have with anybody, I was in hospital fairly recently, and speaking to every member of staff that I engaged with for whatever reason, and just asking them, how are things at the moment? And you learn so many different facets from being in a lift with a trainee nurse and a porter, and the nuggets, the wisdom, the eyes onto the workings of the hospital that you get is fascinating. And then you build a picture of a system that has passionate people within it, but the broken bits. And often people trying to fix those broken bits, but not having the power within the system to do that. And part of what I see patient partners and service user partners as being are seed droppers or pebble throwers, whereby if a staff voice isn't being heard, as a patient or service user partner, I can take what I've heard anonymously and put it into a different context where it is maybe heard differently, because sometimes, and that's a change in the dynamic, a patient or service user voice can sometimes have more power than a staff voice. So that's a change in the dynamic.
Yes. And I think when you're in as a patient, you have that view of the hospital from a very different standpoint than somebody that's walking through the ward or who's sitting in reception. And there's something about staff sitting and observing what's happening in their own areas of work. But also, if you were to have that 2 or 3 minute conversation with every patient that left, it's only 2 or 3 minutes, but I think it would be invaluable. What did you notice that was working well and what wasn't? And what you'd hear back would be phenomenal.
It would be absolutely invaluable.
And if I was to ask you, the one thing that comes to mind when you think of the health service and patient partnership, if you were giving advice to the HSE as a whole, what would it be?
Invest in it, support it. And when I say invest, I don't just mean financially, obviously, but also in terms of what supports do we need to provide for staff, patients, service users collectively to enable partnership to grow. If you open the doors too quickly, you will overwhelm the system. There'll be poor experiences, and that will create negativity. So what is first stage implementation? What are the important parts? Create the standards. Work with those who are working as partners already, staff and service users and patients. What are the standards? What are the things that are good? What are the things that we want to see? What are things we don't want to see? And create policy over time. Invest in people.
Thank you so much for your time today. We really, really appreciate it. I know we've had multiple conversations, and I've always been sorry that I haven't had the opportunity to record them, but I really appreciate you participating in the podcast. So thank you.
Thank you for the invitation. Thank you for the opportunity, because it's people like you who are engaging in partnership that is the living part of it. So thank you.
Thank you very much.
As we come to the end of part 2 of our podcast on patient partnership, we thank both Mary Vasseghi and Christine Fenton for sharing an insight into their lives, motivations, and experience as patient partners. Commitment 1 of the patient safety strategy is to empower and engage patients to improve patient safety. I've been inspired by Mary and Christine, who to me epitomise what that looks like as they shape healthcare through their involvement. We hope you enjoyed this episode, and if you're interested in engaging with people to improve patient safety and create meaningful change, you may enjoy our next episode with Professor Helen Bevan, internationally renowned thought leader and Professor of Practice in Health and Care Improvement. Join us wherever you get your podcasts, and thank you for listening.